So, Dr. Sylvia Eza is a pathologist and clinical scientist with a focus on endocrine pathology. Dr. Sylvia's research has identified the basis for development of endocrine tumors, improved diagnostic tests, and identified targets of therapy of those with those diseases. Dr. Sylvia Eza has published over 500 scientific articles, written 5 books, and co-edited 5 books. Dr. Eza presents nationally and internationally and has received numerous awards on her knowledge. Please welcome Dr. Eza on her presentation of Pathology of Tumors Causing Acromegaly.
So I'm going to start first by asking, how many of you know your pathologist? Somebody in the room? But I'm here today. Thank you. So how many of you know what a pathologist does? A few people do. Good. So what I'd like to do during my talk is tell you a little bit about what pathology is, why we do what we do, and talk specifically about the pituitary in acromegaly and other forms of pathology in acromegaly. So I'm going to start with a couple of disclosures. We always give disclosures when we give scientific talks because we could be biased. And so I have a couple of disclosures because I work with some companies. None of them have anything to do with acromegaly or pituitary pathology, so they're not terribly relevant, but I have to say I have a disclosure. My biggest disclosure is not on the screen. It's actually the fact that I am married to Dr. Izat, who gave the talk earlier today. So I just want to make the disclosure that we talk about pituitary disease all the time. We talk about acromegaly all the time. We see acromegaly all the time. Our kids grew up knowing that Goliath had gigantism and a pituitary tumor. So it just gives you a bit of a flavor of what goes on at the dinner table in our house. So knowing what we know, I'm going to start actually with a story because as Dr. Izat said earlier, the goal for many of us is to understand this disease better, to be able to diagnose it or prevent it, preferably diagnose it earlier so that people don't suffer the long-term sequelae of this disease. And I have to tell you a story, and I have permission from the people involved, to talk about how difficult it is for physicians to grasp this disease. I had a resident who was a pathology resident, and she had no intention of ever doing endocrine pathology or studying the pituitary, but she spent some time learning a little bit of endocrine pathology from me. And I used to tell her when we were looking at pituitaries that acromegaly is all around us, but we don't see it. And this is kind of the story of, how many of you have ever watched House? You know, the show about the great doctor, right? This is the House story, right? Like, you know, the great doctor, Dr. Izat, who sees acromegaly where nobody else saw it before. But I told her that, you know, you have to have a heightened awareness. And this is a diagnosis you can make on the bus or in a restaurant when the waiter who's serving you has acromegaly. Or, you know, there are many places where we see this and we can help people by getting them diagnosed earlier in life. We went to a birthday party of somebody else in the department where spouses were invited, and Dr. Izat and I walked in and we met this young lady with her husband, and we just looked at each other. He had acromegaly. So the next day I called her to my office and I told her, I think your husband may have acromegaly and I think he should speak to my husband. And of course, she was thankful, and they went and had the testing, and he did have acromegaly. And his tumor was sufficiently small that it was removed, and he was completely cured. And she sent me a big bouquet of flowers a couple of weeks later, and on it there was a card saying, Dr. Asa, you told me acromegaly is all around us. I didn't think it was in my home. So that just gives you a flavor for, just to complicate matters further, there's an endocrinologist in their family. So we often miss this diagnosis. It's hard to make. It's a subtle, insidious disease, but if you have heightened awareness, and I know all of you in this room do, and I spoke to some of you earlier today who do the same thing I do, wherever you go and you see somebody, you can say something in a nice way to help them get an earlier diagnosis. So I hope today in my talk with that introduction to help you understand how I see acromegaly, which is a little bit more than what many other doctors see, because I have the great fortune of being able to meet people like you and talk to you and understand what you go through. But I also get to look at little pieces of you in the microscope. So I'm going to talk a little bit about what pathology is and what role I can play and have played in helping you have your diagnosis and be monitored. So pathology, the word means the study of suffering. Pathos is suffering or feeling, but mostly it implies bad feeling, suffering. Logia is Greek for study. So pathology is the study of disease. And what pathologists do is we look at parts of people, whether it's blood or urine or pieces of tissue that come out of biopsies or surgeries, and we try to understand what is the patient's diagnosis. So in a case like yours, it might be acromegaly. We also try to understand what's the prognosis, what's going to happen to this patient. Is this a disease that we can cure? Is it a disease we can treat? Is it a disease that will progress? We try to come up with biomarkers that can help us, and we try to predict the right treatment for each individual patient based on our studies. The autopsy that we usually are associated with is an old technique, and many people, when you say, what does a pathologist do? They say, well, that's the guy who does the autopsy when a patient is dead. That's the old pathology, and it actually goes back to ancient Egypt and Greece, when really smart doctors who were taking care of patients, when they died, they would look at their body and try to understand what they died of. But today's pathologists, we still do have forensic pathologists who try to figure out why somebody died when they shouldn't have. Sudden death or murder, we try to prove that. That's the autopsy pathology. But most of us actually do what we do for patients who are very much alive. And what most of us spend a lot of our time doing is surgical pathology, which is every time you have a biopsy or a surgery and a little piece of tissue comes out of your body, we examine it to try to understand what's wrong. We also run big laboratories where you all send samples. So every time you have a blood test or a urine test, it goes to a big lab, and there are machines and there are people who actually do all these analyses. We also get involved in testing for microbiology. I won't talk about that today. But basically, you can see on the far right a picture of one of the big core labs at University Health Network where I was working, and I ran the labs for 15 years. And essentially, the labs involve biochemical testing, which every acromegalic in this room has had, because you've had blood tests and you've had probably some urine tests as well, measuring your growth hormone, but most likely your IGF-1 and all the other pituitary hormones that we measure to see whether the rest of your pituitary is functioning. And I'm going to talk a little bit about the more important part of what I do, which is the tissue-based, microscopic-based anatomical pathology. Now, one of the problems, actually, I'll just go back for 1 second, is most pathologists either went into pathology because they didn't want to see patients or ended up in a field where they kind of thought they shouldn't see patients. And I just really need to point out that pathologists really do a lot for you, even though we may not talk to you all the time. We are responsible not only for your diagnosis, but also for being custodians of your samples when they come to the lab. We are your representative at quality of care events because we are not directly involved in your care, so we are kind of a little more, except in my case, of course, because I'm conflicted, we're more able to stand back and say to a clinician, well, you did something wrong. Actually, maybe because I'm his wife, I can say that more. So we are trying to act as your representative all the time, even though we may not talk with you. But in a way, it's kind of sad that we don't get to see patients, and I have encouraged patients to talk to their pathologist, get to know who it is, talk to them, ask them for some, ask them to show you what they saw and why they made the diagnosis that they did. And the reason for that is that the pathology diagnosis is actually the gold standard against which everything else in medicine is being measured. So we're the ones who say, yes, you had this disease, and this is the disease that you had, and whether you should be treated with a certain drug or not will all depend on what the pathologist says. And I'm just showing you a couple of photos here of, this is a piece of tissue that came out of a patient. This is not a pituitary, by the way. What we do is we take the tissue that the surgeon removes. In the case of a pituitary, we take all of it because it's not very big. Sometimes we get bigger pieces of tissue and we pick the most relevant parts. We fix them and we keep them in a permanent stored form in a tissue block that it's fixed in a way that it will last for at least 20 or 30 years or more if we ever need to go back and answer more questions about what happened to you. And those tissue blocks, because they're in wax, they're kind of hard, and we can cut very thin slices that we put on glass slides, and then we stain them with pretty colored dyes. Some of them tell us just what it looks like, and some of them tell us what it's doing, what hormone is it making, things like that. So we actually can tell you a lot about your disease by looking at these slides that allow us to correlate what we measured in the biochemistry with what we see in the tissue that we think was the cause of your problem. So as a pathologist, I get to see lots of pretty pictures, and I get to also see things that most physicians don't get to see. This is actually a pituitary from an autopsy. Most doctors don't see that, but this is actually a normal one from a patient who died of something else. And just for you, you can appreciate that the pituitary is this small bean-shaped gland, which you've all talked about, you know about it. How many of you have ever seen one? Probably nobody. Now you have. Now you can put your hand up. So the pituitary has two parts. The front of the pituitary is the hormone secreting part that we're talking about today, where we get growth hormone and prolactin and TSH, all the hormones that Dr. Imran mentioned earlier this morning. And then there's the back half of the pituitary, which is actually a part of your brain. The brain sends down little parts of cells that go down to the back of the pituitary gland and secrete two other hormones, which are vasopressin and oxytocin. Have any of you ever heard of those? Yes, see? So now you know where they come from. They're actually made up in the hypothalamus. They're secreted in the posterior pituitary. Vasopressin is what keeps your water at the right level, your salt and water balance, so that your volume is right. And some of you who've had pituitary surgery may have had usually transient but sometimes permanent dysfunction because of damage to that part of the gland. The front part is what regulates your thyroid, your adrenals, your lactation if you're a woman with prolactin, and your ACTH, which regulates your adrenal function, is obviously critical. And obviously growth hormone, because that's why you're all here today. So this is just another view of that same gland cut across this way, as if I just cut off the top of somebody's head. And you can see here the posterior lobe and the anterior lobe, and you can see how different they look. This is more like brain tissue, and this is not. The posterior lobe, I told you, that's oxytocin and vasopressin. And then the anterior lobe has all these different cell types that are scattered around. Some of them are clustered, like I've drawn here, and some of them are just scattered more randomly. Now, we can actually see all of these cells using stains for different things that each cell type has in it. And these include hormones. So, for example, I can tell a cell that's making ACTH, or a cell that's making growth hormone, or prolactin, or TSH, or one of the gonadotropins that stimulate the testes and the ovaries, by staining for those specific hormones. We also, in the last 25 years, have learned that these cells don't live a very stable life. They're not like us, that you grow up and you are who you are. They can actually change. They can move back and forth. And so some of these cells can actually make growth hormone one day, and then they can start making growth hormone and prolactin, and then they can just stop making growth hormone and make only prolactin, or they might decide they want to make TSH. And that's really interesting because we actually know that you need that. And I'll give you a perfect example. When you're a teenager, you're growing, you need lots of growth hormone. You reach full adulthood and you're a woman and you get pregnant, and all of a sudden you need lots of prolactin because you're going to nurse a baby. And so those cells can actually transform by going through this pathway to give you the prolactin that you need to nurse the baby. And then afterwards, they can go back to making growth hormone. And so all of these are regulated by things that we call transcription factors, like PIT1, estrogen receptor, there's a GATA. There are all these funny names for things that we look at that we can stain for in tissue samples to tell you what a tumor is doing. And this circle just outlines the kinds of cells and the kinds of tumors that we see in patients with acromegaly. And what I really want to convey to you is that acromegaly is not one disease. And Dr. Izat had a slide that had that title, and I'm here to re-emphasize that because I see this every single day. Because each of these kinds of cells can give rise to a tumor, and each cell can actually give rise to multiple kinds of tumors. So for example, whoops, sorry, I went the wrong way. Let's go back. If you look at a growth hormone cell that makes only growth hormone, it can give rise to at least 2 different kinds of tumors. And sometimes we have other cells that can make growth hormone that were either more poorly differentiated cells or cells that were making more than just growth hormone. And so all of these give rise to different kinds of tumors. And the real question is, does it matter? And I'm here to tell you that it does matter, because each kind of tumor has a different biological basis, which means that it's going to need a different kind of treatment. So this is actually a teaching slide for residents in pathology, that when I say to somebody, you've got a pituitary tumor, give me a differential diagnosis, which means what are all the possible things it could be. You don't need to know this. This is not all acromegaly. I just want you to be impressed that a lot of things can go wrong with our pituitary glands. And what I'm going to talk about today is focusing only on one tiny area of that. And that tiny area is even smaller because I'm not talking about all pituitary adenohypophyseal tumors. I'm talking only about the ones that cause acromegaly. And yet, I'm going to tell you about at least 4 or 5 different kinds of tumors. Now, how impressive is that? Now, you guys are well aware that this is a rare disease, right? But I want to put things in perspective. Things can be rare if you start dissecting them to the very microscopic level. And there's always a good thing about saying we want just to talk about acromegaly, and I'm thrilled that you have an acromegaly group. But I also think that you need to have the bigger perspective of working in partnership with other people who have other rare tumors that are related to what you have, because in fact, there is strength in numbers. And Dr. Izat and I work quite extensively with patients who have neuroendocrine tumors in many different parts of the body. And it's relevant to you because actually tumors that are outside the pituitary can sometimes cause acromegaly. So it's good to have friends and it's good to have numbers. So I just want you to keep that in perspective. Now, there have been a number of studies which we actually started in 2003, and we wanted to talk about how rare are pituitary tumors. We worked with a bunch of colleagues to try and look at some statistics, and in 2004, we actually published a paper saying that if you look at autopsy studies, and if you look at just random radiology studies of pituitaries that are taken on patients who walk in for whatever reason, you'll find that 17% of the population has something wrong with their pituitary. Wow, we're not so rare anymore. How important is that, right? We then precipitated a real interest in trying to tear apart our numbers, which is always good. That's what we wanted. People started doing studies wherever they could throughout the world and finding that actually pituitary tumors are present in 1 in 1,000. So we've just gone from being this extremely rare disease to being a rare disease. It's still rare, but it isn't so exceptionally rare. Again, though, I want to put the perspective in context. The pituitary, the anterior pituitary, where these tumors grow, is part of a system of cells that are found throughout the body. There are endocrine cells in the lung, which people never talk about because the lung isn't an endocrine organ. There are endocrine cells in the pancreas. We call them the islets of Langerhans, and that's what causes diabetes. There are endocrine cells throughout the entire gut. Every time you eat, you trigger a signaling pathway telling your brain to stop eating because you have enough nutrients. You're triggering your liver and your stomach and your colon. Everything is starting to function in a way that it should be able to absorb the nutrients and get rid of what it doesn't want. And all of that is regulated by hormones. And guess what? One of the most important hormones in all of those tissues is somatostatin. How many of you are on somatostatin analogs? You all know what somatostatin is, right? It's everywhere in the body. So if you start thinking about the pituitary as part of a neuroendocrine network that regulates how everything in your body works, whether it's eating or growing or reproducing, all of these things matter. And so pituitary tumors are part of neuroendocrine tumors. Now you've got lots of friends and lots of people to work with to help gain traction on something that might not be so rare. And guess what? All neuroendocrine tumors are actually increasing in incidence, while other things like cancers that we now know are caused by infection, like cervix with HPV, or lung cancer caused by smoking, we're kind of reducing the incidence of those tumors. Endocrine tumors are starting to increase. We don't know why. So we've got a lot of work to do, but we also have a lot of political pull if we all stick together and work together on attacking this dilemma. Now, based on that and a number of other things, we actually proposed a couple of years ago that we stop calling these adenomas. How many of you are frustrated by being told that you've got this little benign tumor in your head? I see a few hands go up, yeah. So we actually worked with a lot of pituitary patients, and for many years they kept saying to us, you know, everybody tells me what I have is benign and I shouldn't worry about it, but it's growing in my head and I'm going blind. Right? It's hurting you in so many other ways. You're getting arthritis, your heart disease. You can even get cancer if you have untreated acromegaly, right? So we've said maybe we should just change this terminology because that had already happened in other neuroendocrine tumors, that we started to recognize that they were not entirely benign when they thought they were. And so we came up with this terminology of neuroendocrine tumor that isn't cancer, but it isn't benign. And so we published this paper. It was a consensus group of pathologists, neurosurgeons, and endocrinologists who see patients with pituitary disease. And we said, let's change the terminology. Forget this adenoma stuff because it makes it sound like it doesn't matter. Let's call them neuroendocrine tumors. And that paper actually got a lot of uptake. And guess what? 2 years later, the WHO, the World Health Organization, included it, and me, in a consensus paper that we wrote saying, let's use the same terminology for neuroendocrine tumors no matter where they happen in the body because they are all related. So we just moved pituitary disease up the ladder one step into the bigger world of neuroendocrine tumors where I think they will get a little bit more respect and not just be treated as the little benign things that don't matter. Okay, now again, too much light, my pictures don't show, but you've seen stuff like this, Dr. Izat, and I think we've seen a couple, actually. Dr. Imran showed some MRIs. These tumors can be little tiny things that you can barely see on an MRI. You see that little tiny hole in that pituitary? Here's one that's much bigger, and then there can be a gigantic tumor, and Dr. Izat showed you those gigantic cauliflower-like things that can make you blind and, you know, do horrible things to you. And I just need to point out that size doesn't always matter. I know, because I'm small and people always talk about short people, right? This little tiny thing here, which, you know, little tiny tumor, who cares, right? It's benign. This patient had very, very severe Cushing's disease and actually died of her pituitary tumor. So size is not everything that matters. This is what I see, and these are two autopsy examples, just to show you again the extreme. This is that little tiny tumor that I showed you that, you know, people could say, well, ooh, who cares? It's a little nothing. You find them incidentally at autopsy. We do. Remember the number of like up to 36% of autopsies will find an incidental pituitary tumor, and that's how we got to the 17%. But actually, this killed the patient. And I've seen other examples, and I wish I had one that I had a nice photograph of of patients who've died of heart disease, congestive heart failure, and nobody even thought about it. And at autopsy, I would find something like this and stain it, and guess what it had? Growth hormone. And this patient had acromegaly. The patient would have had multiple joint replacements, carpal tunnel syndrome, all of the problems that we know are manifestations of acromegaly, finally ended up dying of severe cardiac failure, and no one put two and two together, and I made the diagnosis at autopsy. That should never, ever happen. This, on the other hand, is a picture of we took the top of the skull off, and this is the bottom of the brain with the brain removed, and look at this huge pituitary tumor just sticking up into where the brain used to be. These are the two extremes, but you know what's interesting? This person had no symptoms, no acromegaly, no hormone excess, and this patient died of their tumor. So, size does not always matter. Now, when we talk about classification of pituitary tumors, they can be functional, they can be structural, and they can be morphologic classifications. And the most important thing is let's put all the information together, what he sees in the clinic, what we measure in the blood, what I see in the microscope. We want to put that whole story together and come up with something that's going to say, what's wrong with you? Why do you have this disease? And how are we going to treat it? And so, again, I just want to remind you that when you have acromegaly, you may have any one of these different kinds of tumors, and they will all behave very differently. And I'm going to skip a couple of these in the interest of time, but let me just talk specifically about the common tumors that we see in acromegaly, and this is the title Deanna wanted me to talk about, is the importance of granules. Most pituitary tumors are actually what we call densely granulated tumors. And they usually are making only growth hormone. Sometimes they will make a little bit of prolactin as well. And these tumors are the classical tumors that we associate with acromegaly. And the patients who have these tumors usually have very florid symptoms of acromegaly. Everybody made the diagnosis clinically, and everybody knew exactly what was coming out when the surgeon operated. There's another kind of tumor called a sparsely granulated tumor. And this tumor actually has very little growth hormone in it, but it has growth hormone production and secretion. We don't see it being stored, but patients who have this kind of tumor usually have larger tumors when they present. Their acromegaly is not so florid. You can't just look at them sometimes and say, oh, they have acromegaly. And the treatment for patients who have these two tumor types is completely different. And the reason for that is that they have very different biological basis. This is just to show you what those stains look like. This is a densely granulated tumor. You can see it's really pink because of all those granules in the cytoplasm. And this is a stain for growth hormone, and you can see there's lots of brown, and that means there's lots of growth hormone in it. The stain at the end is a keratin stain, which is just keratin is what we have in our skin, and that's what normal cells look like. But it's important because the other kind of tumor, which is the sparsely granulated tumor, has a completely different morphology. It's not so pink. The cells look kind of wild. You can see that there's not very much growth hormone in this, but what's really interesting is that the keratin in this tumor type is completely different. It's little balls that look like little knitting balls, right, or little marbles. And that's what predicts a completely different biology. And I'm going to show you that because if you go back now, I put these slides in a different order, but here we go. If we look at the densely granulated tumors, we know that they have a very high level of signaling telling the cells to make growth hormone. And the signaling goes through a process of something we call cyclic AMP, which doesn't matter to you, but the important thing is that's what makes the growth hormone happen, and that's what somatostatin stops. And so if you've got lots of cyclic AMP and you treat that patient with somatostatin, they're going to respond really well to somatostatin treatment, and their growth hormone levels will fall. But if you look at densely granulated tumors, the reason that they're not densely granulated is completely unknown to us, but we do know that they don't have lots of cyclic AMP. They have something completely different. They have a different level of something called STAT proteins, which are STAT3 and STAT5. And so the fact that they don't have high cyclic AMP makes it perfectly clear that these are not likely to respond very well to somatostatin analogs. So when you have a pathology report and you have a patient and you say, this patient had a big tumor, very low growth hormone levels, they've got a densely granulated tumor, I should be prepared for them not to respond to the therapy that I would normally give to somebody who's got a densely granulated tumor. So let me skip a few too many word slides. So those are the two commonest kinds of tumors in acromegaly, but remember I told you there's the sparsely and the densely granulated ones where it's all about the granules, and actually it's all about the keratin if you want to be honest. But there are also some other tumors that are much more immature cells that don't look like anything that's in the normal gland that also can cause acromegaly. And it's interesting because the acromegaly in these patients is usually atypical. In the old days, we used the term fugitive acromegaly. It was like it wasn't so obvious. You'd think, patient may have acromegaly, but not really. And then you measure their hormones and it's abnormal. But then when you measure it a second time, it's normal. And you're kind of struggling with what's going on here. Do I really know what I'm talking about? Well, these are the tumors, and Dr. Izat showed you before something interesting about them that I thought I had a picture of. I guess I took it out because he had it in. These tumors invade down on radiology instead of invading up as cauliflowers, the way the usual tumors do. And so if you have a good radiologist, they can actually tell the difference between a sparsely and a densely granulated tumor just based on some of the imaging. They can tell that it's growing down instead of growing up, and then when I get the pathology specimen, I can see that this is a completely different kind of tumor that doesn't look like either of the ones that I showed you before, and this is going to be one of those, what we call a stem cell tumor, which is less well differentiated and less likely to respond to some treatments. Ali. Yes, they do. That's an interesting point. So both, if I go back to that schema that I had, these are just epidemiology numbers. Both of these tumors, if you realize, so the PIT1 lineage stem cell gives rise to somatotrophs and mammosomatotrophs, and mammosomatotrophs give rise to lactotrophs that make prolactin. Both of these cell types make prolactin, and we think that both of these kinds of tumors, whether they're the poorly differentiated PIT1 lineage or the acidophil stem cell, these are the tumors that they can present with acromegaly, they don't always, and they can also secrete prolactin, and some of them even secrete TSH as well, because they are poorly differentiated stem cell tumors, essentially. So, and that's why they grow downwards, because they're much more invasive of bone, and if you think of how the pituitary develops, it invades through to get where it needs to. So the fact that they can invade through bone is also reflective of that kind of phenomenon. So, that's the acidophil stem cell tumor, which is the second type of tumor. This is more of an oncocytic stem cell, if you like, and these are the ones that will often present as fugitive acromegaly as opposed to florid acromegaly. So I think I don't need to talk too much more about pathology, because you just want to understand that big picture that there are many different cell types, and pathologists should be able to come to the right diagnosis to give you prediction for your treatment. I also want to remind you that there are a couple of other very unusual things that we need to be aware of, both clinically and as pathologists. And this is the fact that not all acromegaly is mainly a pituitary disease, or primarily a pituitary disease. So if you remember all those pictures that Dr. Imran and Dr. Izat showed you of signaling pathways with things stimulating and inhibiting growth hormone, one of the most important things that stimulates growth hormone is growth hormone releasing hormone. And it is normally produced in the hypothalamus, where it stimulates the pituitary. Sometimes we see hypothalamic tumors that cause acromegaly by stimulating the pituitary. But another important thing to be aware of is that sometimes you can have a tumor in the in the pancreas, in the lung, in the adrenal gland, in other neuroendocrine tumors of the body. And they can make growth hormone releasing hormone, which then will stimulate the pituitary to develop acromegaly, and yet the patient doesn't have a pituitary tumor. And sometimes the pituitary gets kind of large, and then the clinicians say, well, the pituitary is enlarged, maybe it's there, and they take it out, and I say, no, this is actually hyperplasia, it's not a tumor, and I won't go into the details, but I can tell that. And I will tell them, go back and measure the growth hormone releasing hormone, because what you really need to do is scan this patient for a tumor in their lung or in their abdomen. Okay? Important news, right? One last thing I'll just say is that the importance of early diagnosis and being able to treat patients properly is recognition that everything that we see is not static. Your tumors don't suddenly appear the way they were when you were diagnosed, and you probably all know that because it takes many, many years. But I have to reemphasize that there are just some times when we can never, ever treat a patient, and Dr. Izat showed you this already in one of his slides, that once a tumor gets out into the cavernous sinus around the carotid arteries, we can never surgically remove it. And so our goal is to help patients get their diagnosis while their tumor is like the young man I told you about at the beginning of my talk. When it's still inside the cella, a surgeon can go in and remove this totally. Sometimes even when they grow up like this, we can still get them out, but as soon as they start getting out sideways or too high up into the brain, that's when we cannot cure a patient who has acromegaly. That's when we need to start using the drugs that we use, whether it's somatostatin, or in the case of people who don't respond to somatostatin, there's pegvisomant and all the other kinds of treatment that we can provide. But it really would be nice to reach the day where we diagnose patients when we still can treat them and cure them so they don't have to be on lifelong medication. So we've also come to learn a lot about the molecular basis for these tumors and the fact that some of these patients, some patients like yourselves, may have familial predisposition. In Dr. Imran's talk, he mentioned AIP, a patient who was diagnosed very early in life as a giant. Some of these patients have genetic predisposition to disease. And so one of the things we need to talk about also is, can we tell you right away whether or not you're likely to have someone else in your family who we should be screening to catch this much earlier in life. So there are many different parts of what we do in pathology that we can actually help you to understand better what's going on in your own body. And I am certainly one of very few pathologists, but I hope many more will follow in my footsteps to actually say, I'm here to answer your questions and I'm happy to talk about your pathology and help you through this. So happy to answer any questions if you have any. I see Dr. Priptani has arrived, so I just took your talk and we switched things around here, but I'm happy to answer questions and then we'll go into his talk. Yes?
After the tumor is removed from surgery, I know that it's sent off.
Mm-hmm.
So I would like to know the actual protocol procedure from the time of the removal of our tumors. What happens?
Perfect question. So, in detail? Absolutely. So when a surgeon removes tissue in the operating room, they are required by law to send it to pathology for documentation and reporting. And so what they do is they collect the tissue and they are supposed to put it into a fixative that will prevent it from deteriorating, because the minute we take tissue out, it doesn't get oxygen anymore and it starts to die. But we have a fixative. Most people use something called formalin, which we put the tissue into, and it keeps the tissue fixed in a way that it will not deteriorate any further. Now, I have to make a comment that when pituitary surgery is being done, as most of you know, it's endoscopically the vast majority of times, and the surgeon is operating through a tiny little hole with a microscope, and whenever there's blood, they suck the blood out with a suction machine that lets them get the blood out of the way so they can see what they're doing. So it's very important. Now, that suction machine usually goes down the drain. And so sometimes we actually don't get the tissue we should get. However, in a good institution, the surgeons are taught to put a filter on that suction so that everything that gets suctioned goes into a filter trap that then goes to the formalin. They usually will pull out pieces of tissue, though, when they see the tumor and send it to us. And a really good surgeon might say, oh, I think I'm at the edge. Let me see if this is normal pituitary just to make sure. And so they might give us a few samples, separately or not, to tell us where they are. That tissue in formalin goes to the pathology lab. It's got a label on it that has your name and the time that it was done. It goes to the pathology lab where we process it through big machines like the one I showed you in the picture of the lab. And those machines actually make the tissue no longer water soluble. It has to be infiltrated with wax to fit in the wax block that keeps it permanently. And those wax blocks are kept in pathology, and they are supposed to be stored for a certain amount of time that is dependent on which province you live in, so that we can always go back and tell you something that we might have missed the first time around. And then those wax blocks get cut up and used for all the different studies that we do, the different stains and the different analyses that we can do on those different pieces of tissue.
So how would a patient be able to obtain the pathology report that
Perfect. So anybody has access to their medical record in Canada. If you ask for it, you should get it. In some places, I know many of the hospitals where I've been familiar with the process, some patients have access online to their record. And your pathology report should be available to you in that medical record, and you should be able to download a copy of it and keep it. And then, of course, there's always the question of, what if I want another opinion? So people are always very, like if somebody makes a diagnosis and you say, well, I want another opinion, you ask your doctor, can I have another opinion? And they'll send you to somebody else, right? The same is true in pathology. If you have your pathology report and you say, gee, I want a second opinion, you can ask for that. And you can ask them to send it to the person of your choice. It's your right, as in all of Canada, to have a second opinion. And just like you can go on the web and say, I heard Dr. Imran give a talk and I want him to give me a second opinion on my diagnosis, you can do the same for your pathology.
Even across provinces?
Even across provinces. We do actually have agreements among the provinces that they will allow you can get it actually, I think, for free across provinces, but if you want to send it to China or India or the US, you can do that too, then you have to pay.
What about
The United States, you can ask for an opinion in the United States, absolutely. You have to pay for it. Everything in the United States has to be paid for, right? Unfortunately, yes. Yes?
My question is you were talking about the sparsely and the sparsely and densely.
Mm-hmm.
So can you tell without actually taking a sample from the pituitary what it is?
That's a great question. So you can't tell for sure, but as I mentioned very subtly, and I just got pictures this morning that I couldn't incorporate into my talk, but there is now a literature showing that you can actually predict on radiology which of those kinds of tumors you might have. And that's based on, most of you have had MRIs, right? When you have an MRI, there are different ways of looking at the MRI signal, and they're what we call T1 and T2 and T3 weighted images. You may have seen that in your radiology reports. So on T2 weighted imaging, there's a difference in the intensity of the pituitary tumor based on that granularity. So if you have a sparsely granulated tumor, it's going to be really shiny hot on a T2 weighted image. Yeah. Now, it's not 100% because some of those unusual tumors that I talked about are also sparsely granulated. And not every tumor reads the textbook, so you can't always be 100% sure, but you can certainly, a good clinician can look at the patient, look at the radiology, get the history, look at the blood levels and say, I think this patient has a sparsely, or I think this patient has a densely. Not a lot of them do that, but the ones who are good and do this all the time, they're usually right.
Can a tumor change? Could it be
Oh.
sparsely and go into densely?
That's a really good question. I don't have an answer for you because I have not seen enough patients, fortunately, who've had a tumor that's recurred multiple times over time where I could say I saw it change. That being said, there are sometimes mixed tumors, and you kind of wonder, did it start as one and it's turning into another? Those are rare, And so we really can't say. There's an intermediate form, but I won't talk about it because it's really a densely. But sometimes we do see mixed patterns that makes you think maybe. However, the genetics of these tumors is different. And so usually, once you have a genetic program that's changed to cause that tumor, it usually stays along that pathway. It may get worse, but it doesn't usually convert to a different pathway. That's not to say it won't happen, but not usually.